Hello, everyone, and welcome to the Well Health webinar series. Today's webinar is part 2 of our Revenue Recovery series, focusing on scheduling appointments at scale. Just a couple housekeeping items to go over. We'd like to remind everyone that the Q&A feature is available and our Well Health product specialists are standing by. So feel free to send in your questions using the questions feature in your GoToWebinar dashboard at any time throughout the presentation. We also have an accelerated revenue recovery handout that is accessible for you to download from the dashboard. This webinar is being recorded, and the recording will be sent to everyone later today. And with that, I'm going to hand things over to our host, Ben Bible.
Perfect. Thank you, Sarah. Welcome, participants. Welcome back, repeat viewers from webinar 1, and welcome new viewers. Good afternoon, everyone. My name is Ben Bible, and I have been with Well now for just over a year as a client success executive. Today, I'm joined by Meg Aranow. Meg is a Platform Evangelist at Well Health. Before joining Well, she served as Chief Executive Officer for Adaris Health and Senior Research Director with Advisory Board's Information Technology Strategy Council. Previously, she was Vice President and Chief Information Officer for Boston Medical Center for more than a decade. With that, I'm going to go ahead and hand over to Meg now to get us kicked off.
Thanks, Ben. I appreciate it. And I'll add my welcome to everyone who's joining us today. And also let me say thank you to everybody who's on the line, whether you're at the bedside or whether you're working in support of the bedside. Those at the bedside, we know that not all the heroes have direct hands-on exposure to our patients, but we know that everyone's work is important, and we're happy to be serving you in our limited capacity. And Ben, I'm going to ask you to just go back one slide, I think, to get us kicked off. There we go. Thank you. So just a refresher on the series that we put forth. We realized as we saw the pandemic progressing that we would soon, we had all hoped sooner than today, but soon be in a position where we would need to be thinking about what was going to happen post-pandemic, or really, I guess what we've come to know as post-surge, since we know that things are not moving at the same pace and in the same direction across the country. And as we thought about it, we developed an approach that we think will work well as soon as you are in a position where the surge is receding. And we know that that's not true for all of you on the call today, specifically those of you who are joining us in California, Texas, Florida, Georgia, or Illinois. The latest statistics show us that you've been surging for the last 7 days. So this is a planning exercise for you. And again, our thank you for all of your support. But for the rest of us around the country, the recovery is, if not in motion, at least in sight. And so thinking about these steps, reassure, reschedule, and recover, becomes appropriate. So in the last series that we did, in the first of the series that we did, we talked about reassuring patients. And just to recap a little on that, our patients were hearing in local news stories, in national news stories, and often from provider organizations themselves, that they should stay away for anything that involved routine or elective care, and that our hospitals were overwhelmed in some cases, or preparing for a surge of patients that would need critical and immediate care, the COVID victims. So we created this, and it was intentional and it was appropriate, but it has a lasting effect, particularly as social media has picked up on some of the risk factors, which are real risk factors, but which do get amplified through our social media channels. And so the result of all of that messaging was some of the statistics that you see on the screen, that people felt it was risky, and they weren't wrong about that. That many people, 60% of the people that were surveyed, thought it was somewhat likely or even very likely that they could actually contract COVID if they went to the hospital. And that overall, 40% of patients delayed care. And the CDC has since actually come out to say right around that 40% mark included 40% of heart attack victims, of people potentially suffering from stroke, and of people with high blood sugars. So very vulnerable populations, very much what we would call our at-risk population, staying away. And I think time will tell what the effects of all that delayed care actually will be, but I am sure that we will see it represented in the health factors that we're able to measure once things subside a little bit more. We also saw that drop in emergency room visits. There was a recent study about decrease in stroke assessments. So we think that there are likely, since there's no reason that strokes themselves actually decrease, that likely we've got patients that have suffered some sort of neurological harm that has just not yet been diagnosed. So all of that is kind of looming in front of us, and that becomes our next challenge, to reassure patients to the extent that we can bring them back into our facilities in a way that's safe, and that we do it in an orderly way and in a way that's going to have the biggest impact on health outcomes of our patients. Ben, you want to go ahead to the next slide? So with that, we face this enormous rescheduling challenge. So we're talking about rescheduling previously deferred visits. At the same time, we also need to know that we need to try to recapture all the missed referrals that we had. So this isn't necessarily deferred care as in care we knew about, but rather for those patients that we never even heard about that might have come through our normal referral channels. And so all of that is a capacity management issue for us that we need to deal with. So among the things that we need to come to terms with are the best ways to reach out to our patients and bring them back. And we would encourage you to use all the technology, not just ours, but all the technology that you have at your disposal, whether that's your portal, whether that's reaching out through IVR, whether it's using text messaging, your websites, whatever technology that you have, and whatever way you know your patients want to be reached. Obviously, that's the best way to do it, and we'd suggest you probably need to be doing all those things at once. You also need to think about the order and the sequence in which you want to bring back patients. Some people may be bringing patients back in based on departments, so staffing up departments or specialties at a time and seeing how that goes before we move to the next specialty or department. Or you may want to bring back those people you feel are most at risk, those people that have missed their health maintenance for the chronic conditions, the diabetic patients or the heart failure patients. These will be decisions that you will make in concert, of course, with your clinical leads, as well as facilities management and other people, since many of us have rearranged our access to our buildings and have rearranged the staffing component that goes along with that access. All things to be considered. Some people may think about rescheduling in large tranches. You may just say, look, we shut down the week of March 18th. I'm going to open up fully, and I'm going to bring back all my patients that had been scheduled for that week. I'm going to slot them into week N, whatever that opening week is, and then just go week by week. You'll, of course, have to balance the staff availability that you have there. Many of you have furloughed staff, and some have been permanently laid off. So in what way do you want to bring back that staff, and how will you deploy them? We will say that this is an opportunity to rethink about your staffing models and to rethink about the way technology can augment or play into those staffing models, as well as your facilities management component. Do you want everybody in a call center or in a central location? Do you want to push people out into the practices? With every challenge, there is an opportunity, right? So this is an opportunity to rethink some of that. And then also just think downstream. This is some of the work that we've been hearing about from our current customers, the availability of what's going to happen, particularly when you're bringing in those elective surgeries, what's going to happen post-discharge. How safe is their home? How is it a multi-generational home where they may be at risk still for COVID, or are you certain that they're not? Are there available post-acute beds if that's something that you need? So all this will have to be taken into account as you think about rescheduling. And Ben, I think you've got some real concrete examples to talk about as well.
Yeah, absolutely, Meg, and thanks for handing over here just real quick. Just talking through some of these challenges and what everyone is facing today, it really kind of brings some of the powers of what we're able to do through our software and through some of our features. And not only do you have these challenges today that are related to specifically to COVID, and a lot of these have come about because of that, but really, how are you utilizing the Power Well, or how can you utilize the Power Well to reach out and update those patients for COVID information? But something else that we're actively seeing right now is natural disasters, such as hurricanes or tornadoes throughout certain regions or just across the United States. Passing that information, again, specific to COVID, you may be passing information about how to access facilities or where to park or how to park and get that virtual check-in. And then on the other side of that, again, talking about those natural disasters that we're currently experiencing with Hurricane Laura just recently, Hurricane Hannah before that, and really getting that information out to patients, letting them know of those closures or how the hospitals or the practices or what have you may be reopening. And really just being able to get that mass notification or that mass update out to your patients. We've seen this here recently, again, specific to COVID, but now with the season that we're in, we're seeing our broadcast features, our campaigns features being utilized to really get that mass piece of information out of there. And then on the flip side of that, especially talking about the rescheduling piece, we're seeing those same tools as well as others in the Well feature set being utilized to bring those patients back and get those patients back in the door, seeing their providers and ensuring that their care is continued through these trying times. So very useful tool on our end. And again, not only the COVID challenges that we're seeing, but now just the natural disasters and then other things that just kind of come unexpectedly. We've seen these feature sets be used with some of our other clients throughout the year. We had a large health system recently have a water main break in one of their primary buildings. Through our tool, they were able to notify patients immediately and let them know that their appointments were canceled for that day. Again, through that same tool, they were able to bring those patients back in and get them rescheduled with their providers. Again, not COVID related at all for that specific scenario, but really shows the power of the feature set with Well. And then Meg, I'll go ahead and move on to the next slide, and thank you for letting me jump in there.
You bet. Thanks, Ben. So no surprise here. We're going to be very bullish about technology, right? But I think you knew that when you were tuning into this webinar. We believe it. That's why we do what we do. And we can see here that the manual method for rescheduling, when we have to reschedule at the scale that we just laid out, is going to be very hard to manage. And so we want to encourage all of you to think about the use of technology, all the technology you have at your disposal. We don't believe that existing call centers or your practice schedulers, depending on how you're organized, are really going to have the bandwidth necessary to do all of these things at once, this reassurance and rescheduling. Because even though we've represented them as kind of sequential, we know they're not, right? Patients are going to continue to need to be reassured. It will take longer to schedule these patients because they'll have concerns and questions that we need to answer. And also because our scheduling is going to become more complex. And I'll touch a little bit on that later in the webinar. So we don't think that a manual method will scale. We do believe that technology will allow you to achieve a one-to-many kind of ratio, whether that's opening up your portals more fully for self-scheduling, whether it's employing symptom checkers as a screener, as opposed to using a manual attempt to screen patients for their wellness before they're returning to your facilities, whether it's the use of remote technology, remote registration technology, so that you're keeping folks outside your doors and can better manage your access points. Many of our co-workers have talked about the idea of needing to have separate entrances or even separate facilities. One of the things we'll post for you to see later on is some TMS guidelines, which suggest you may actually want to segment your facility so that you have a COVID wing or building and a non-COVID wing or building. So all of these things are going to make the challenge of scheduling much more daunting. Also think of using your technology as staff augmentation to the extent that you can more fully deploy your telehealth where it's appropriate, or the use of kiosks where perhaps you weren't using them before for registration. All of these things will help you manage the scale. Go ahead on to the next slide for me, Ben. So one of the things that we're talking about for rescheduling after COVID is the need to reimagine the patient journey. And I've talked about employing tech, and I think a lot of people are talking about employing technology, right? Not just us, but making sure at the appropriate places, all of the technology that you can use is in place. I think that the key here is, while we went into this sort of alternate mode during the pandemic, when we come out of it, we're not going to come back to life as it was pre-pandemic. We've learned about our patients' acceptance of the technology we've been using, as well as our clinicians' acceptance of the technology. So when we come out of it into the overused phrase of the new normal, we can expect that there's going to be a different blend of in-person and technology-assisted visits. It's going to be a blend of on-site and remote, and that's going to become the new care journey or the new care path for patients. There'll be some challenges with that, not just in the scaling of your technology, but other kinds of challenges as well. University of Pittsburgh Medical Center just recently did a study and reported that they expect that there'll be some telemedicine or telehealth slots that go unused as they try to find that right balance again. They've also created, this is really interesting when we talk about a new care path, they've created a rapid access video evaluation. So what they're doing is they are actually evaluating their patients in a remote way, and then they're determining what is the best location of care for each of the care touch points this patient needs. In other words, let's do a new care plan so that we very intentionally deliver some care off-site and some care on-site. And that's not necessarily because of a COVID risk. It's just a new way of managing patients and thinking about what's best for patients, what is more satisfying for patients, and what's the best use of your limited facility resources. So as we said, the new normal, the term that's overused, but very relevant these days. Ben, you want to go ahead to the next slide? One of my favorite maps. So this is a map of telehealth utilization put together by the Chartis Group and Kayatra Labs. What we see and what you all know is that telehealth boomed during the height of the pandemic, as high as 50% across the national average. And now it's projected to stabilize around 18% according to this study. We here at Well have done our own study, and we had pegged it as about 15%. Not a huge difference between those two numbers, so I think everybody's in the same ballpark. Our numbers are based specifically on our customer base utilization. So I think we're all thinking the same thing. So 15%, while much lower than the peak, is also much higher than the pre-pandemic rate. So as we look at that shift and we start to recalibrate to what will be on site and what will remain telehealth, it's very likely, as I mentioned before, that you're going to have some telehealth slots that go unused. I mean, it's just going to be impossible to get that blend right, to have the right capacity in the right place until we get to a more steady state and we have more experience on which to base our projections. Our advice here would be to watch how you contract. Look at your contracts with your telehealth providers and see if you are contracting by slot, by month, by episode, if you've got different caps on that. Obviously you want to minimize your financial risk as much as possible during this time of transition. So it's a good time right now to go ahead and check those contracts. Another thing to help you think about this reopening is at the end of our webinar today, we're going to post the CMS guidelines in the chat window for those of you who haven't seen them yet. So CMS has some very specific guidelines to help you think through all the things that you'll need to think about as you're bringing patients back to your campus. Everything from staffing and facilities to the COVID, non-COVID separation, PPE, ability to schedule, all of those things. So I think it's 7 or 8 different categories around which you could build your own individual plan so that you're assured that you are reaching out to patients in the right cadence to bring them back to a facility that's prepared to handle all of their presenting symptoms in a responsible and safe way. So it's a good guideline, and we'll post that for you. Ben, I'm going to hand it over to you now.
Absolutely, Megan, and great point there just to lead into this next topic. Meg definitely touched on some of the patient demands and what they're wanting. Obviously, telehealth is driving up, especially from where it was pre-COVID and especially to where it's at today. And then some of the other factors that we've been looking at is really on our clients' end and what some of their pain points are. You as viewers today and our clients that we have today, they know what those pain points are. They experience them every day. And so when we are working and putting this together, we're asking the questions what are you seeking as far as the right solutions for those pain points? And then we have of course, some considerations. We would like for folks to take a look at making sure that the tech that they're looking at includes appointment rescheduling at scale. You want to remove as many barriers as possible for those patients who may be hesitant. I know Meg touched on earlier that 36% of folks are a little bit nervous to come back into the hospitals and practices just because of COVID-19. So really removing that barrier for them to feel comfortable to come back in and seek out that care. And then optimize the return on your efforts by mapping tech features to known pain points. And so, how does play into that piece? So based on those considerations and meeting kind of the market and the customer needs, we rolled out what we're calling the Accelerated Revenue Recovery Package, or ARR package. Essentially, this enables seamless communication to reassure patients, reschedule appointments, and recover lost revenue. ARR is a tailored interim version of the complete platform, and that can be fully integrated with the EHR, and it can be implemented in just 10 days, which is pretty phenomenal. The reason it's implemented or can be implemented in just 10 days allows for you to access and start utilizing those feature sets immediately or almost immediately to get back and communicate with those patients. And really the idea behind that 10-day implementation and the tailored package itself is for customers who need fluidity, and of course is there to match those reactive needs. We also have as far as the terms for the ARR package itself, we have a 90-day term, and really in that time frame, we've seen some of our other clients utilizing this where they're able to provide and prove out Well's return on investment, or ROI. So a really great package that we've rolled out. I'm seeing extreme success with it, and really focus on making sure to get those patients back in the door, but also solve some of the pain points that you as clients are seeing today. So Meg, I'll jump into our next slide for self-rescheduling.
Great, thank you. So we're going to wrap up and keep this very brief, other than any questions that you may have. Ben and I will definitely hang around and listen for those and respond as best we can. But I do want to close with planting the seed with you around this idea of self-rescheduling. So I've talked in the last 15-20 minutes or so about needing to be able to schedule at scale and needing new mechanisms by which to do that. When I first heard the Well engineering team talking about self-rescheduling and pointing out that, again, we're not the only folks that do this, but I'm most familiar with our mechanisms for doing it. When I first heard them talking about it, I was kind of overwhelmed, because from my days of being a provider organization, scheduling was hard. There were just so many permutations of appointment types and individual provider preferences, and needing to understand the health status and mobility of the patient themselves, equipment availability. It all seemed very overwhelming to me. And I think, truthfully, that's still the case. But what we're doing here, and what I would suggest you think about doing, is that we're taking those first steps in ways that are reasonable and in ways that we really feel we can achieve results. And so that, for us, that means we can support some self-rescheduling with our Epic clients for the same appointment type in the same provider. So we're not taking that big step into the complexity, but we're taking the first step into what I think is going to be a very advantageous approach to this. And so I'd encourage you to think about that for your own organizations. And I'll just close by saying that within the last 48 hours or so, the CDC has recommended to health organizations and health departments that they begin to get ready to be able to administer COVID-19 vaccines as soon as the beginning of November. A vaccine clinic would be one of the perfect places to work on rescheduling or work on self-scheduling, excuse me. Again, keeping things simple. It's easier to look at those things as a first step than when you do what I did, which is basically get intimidated by looking at the whole breadth of what a rescheduling challenge may look like. So with that, I think that concludes where we were going to take our prepared slides. And Ben, I'm going to turn it back over to you, or is it to Sarah? I'm not sure.
Absolutely, Meg. So it gets us to our question and answer slide here, and we do have a couple of questions that had come in. I just want to high level review these, and then we'll monitor the webinar here to see if any additional ones come in following that. The first question that we had submitted is, what are some of the things to remember when rescheduling patients? And so I think one of the most important things during this time and to remember at this point is really just that communication expectation. Right now, there are just a lot of things swirling around. Again, just throughout the slides today, we touched on the nervousness that patients have. And 95% of healthcare facilities are enforcing some type of protocols for their patients to either enter the facility or even visit family that are maybe in the facility. So those things can include masks, temperature checks, physical distancing, the virtual waiting rooms we touched on, and then of course, like I said, whether a family or can actually come into facilities or they may not be able to come in there at all. So definitely that communication or a communication platform like ours and the ability to let those patients know what to expect as they're coming into the facility would be huge, and definitely something we recommend as far as what to remember when bringing those patients back. And then the second question we received, which is, how are patients preferring to reschedule? So this is a really open question. There are just a number of ways. Some of the ways we've seen most recently, and just throughout, obviously with us being a communication platform, is that two-way or bi-directional communication, meaning the patient has historically received texts for appointment reminders or just notifications coming in from their facility or their hospital or their provider, and then they're able to actually communicate back with that team, and they're able to go in and reschedule just via direct text communication, and once they're verified as an actual patient. We've seen patients utilize via two-way texting or via reminder messages going out to utilize their patient portals, having redirect them back there to look at open schedules and see what their providers' availability are. So again, a very open question, but lots of different ways to tackle that one for sure. And then Meg, I'm not sure if you have any additional pieces to add to those two, and I'll take a look over here and see if there are any questions that are coming in.
Yeah, thanks. To the first question, I would say, just to point out, and we touched on it a little, that previously we know that many of our customers and healthcare organizations around the country were thinking about the precautions that needed to be taken before patients came back on site, such as temperature checks, making sure people had masks, etc. I think now with this latest information that folks are optimistic that there may be a vaccine by the end of the year. It's another piece to throw in there. Are there some situations in which you would require someone to have a vaccine before certain types of appointments, be they elective procedures or whatever? So it's another piece to throw into the mix. And then regarding how patients want to schedule, I think you covered the landscape there very well. I'll just add that for those of you on the phone who maybe are supporting pediatric practices, there is something to think about here, of course, relative to family visits, right? When I as a parent want to bring in all my kids at the same time, right? For those missed vaccines, that's another missed opportunity we've had during the pandemic. Is that going to be something that you allow or you don't allow any longer based on trying to limit the number of people in the facility? So that's just the other point I'd make there.
Perfect. Thanks, Meg. And team, I don't see any additional questions coming in. I do want to take this time to thank all of the participants today for jumping on the webinar here with us. Hopefully you found this information to be useful. Of course, we will have a recorded version of the webinar available, and we will be responding to additional questions if they do come in. For any of the customers that may be interested in more information, please of course, feel free to reach out to your well point of contact, or email us at support@wellapp.com. If you would put the Revenue Recovery Series Part 2 Reschedule in your title or in your subject line, that'll definitely key into the correct folks to make sure we get those questions answered for you. And if you are interested in learning more about the product itself, please email well@wellapp.com, and we will, of course, reach back out to you. Again, thanks everyone for your time today on the webinar. We appreciate it.